So this is the voice thread entitled How to Effectively Precept Undergraduate Nursing Students. And this is designed for the Invest in Nursing Scholars Program at the University of North Carolina at Chapel Hill. And we want to start off this voice thread by thanking all of you for agreeing to work with our students and to share how excited they are to be placed with you all. By agreeing to precept our students, you will take on many roles. You will lead and educate our students. You will coach our students. You'll encourage them throughout the course of their shifts with you. You'll evaluate them on their strengths and weaknesses and offer suggestions for improvement in their tasks and behaviors. You'll advocate for them so that they can best understand what a day looks like in a community health center. You'll also serve as a role model and a mentor. Remember, many of these students are considering careers in primary care, and this will be their first opportunity for some of them, to be in a primary care environment. All of these students you'll be working with have had clinical experience in a hospital setting, but few of them, if any, have had experience in primary care. We are defining preceptors as experienced and competent staff nurses, LPNs, medical assistants, and nursing assistants who've received formal training to function in those capacities and who serve as role models and resource people to our students. They will merge the knowledge, skills, abilities, and roles of both coaches and mentors and help our students develop and mature into strong practicing professionals. In order to meet the competencies laid forth as a preceptor, we want you to maintain your knowledge base and skills. For example, if you are giving vaccines and the CDC has issued a new guideline, we hope you would have that knowledge and share it with our students. We hope you relate your previous experiences to situations occurring with the student. So please feel free to bring in previous experiences and situations that you feel are relevant to the day, even if the student isn't present in that room or wasn't there 3 days ago when you encountered this patient situation. Sharing those experiences certainly have benefit. You will always engage in assessing yourself and ways that you're functioning throughout the day and whether those could be made more effective. You'll participate in learning activities to meet identified opportunities for growth and support your functioning in your preceptor role, and one of the ways that you're doing that is by listening to this voice thread. You'll identify support available for you in fulfilling your preceptor role. So certainly the faculty here at UNC Chapel Hill, including myself and Dr. Megan Williams, are here if you have any questions, concerns, or issues that come up with students. All of the nurse managers at all of the community health centers have our contact information, and we hope that you won't hesitate to contact us if you have any questions. The American Nursing Association and National League of Nursing has very helpful websites, and of course our own North Carolina Board of Nursing website may be of use. We hope you will exhibit effective communication and establish collegial relationships with the other members of your workforce team and us. So what are the responsibilities for you as a preceptor? Well, on the first day that your student arrives at the community health center, they may be feeling a lot of emotion. They might be nervous. They might be unfamiliar with the community health center on that first day. And some of them may be confused as to what role they're functioning in as well. We want you to take the time as you have it in your busy schedule to orient our students to the nursing unit. Give them a tour if possible. Show them where to put their belongings. Explain to them where to park. What the culture looks like for lunch. What procedures are done on that day. Where's the lab equipment? So the first day really can be more of an observation day depending on how it goes. After that first day, we want you to feel like you can facilitate their learning. So that means that any role that you're doing that you think a student would benefit from, they will do with you. So as you're calling a patient back to the treatment area, the student will be standing next to you. And over time, we want to see progression in the role of the student. So they should be able to maybe observe for the first day, and the second day sort of shadow and do tasks with you being present. But by the end of the clinical experience, certain tasks such as taking vital signs, taking a patient back to the room, cleaning up the room after the patient left, some of those skills can be done independently, assuming you feel comfortable with that and you've watched them do those skills appropriately a number of times. Establishing a schedule on the first day is also very important. You might need to take a vacation during the time that the student's there. If that occurs, we are certainly open to the student not coming in that week, or maybe working with a different person in that day. All of the community health centers that we have visited have different schedules. So, for example, one community health center might have a Thursday where they have a cardiology clinic, and another community health center might have extended hours for a farm clinic. It's our hope that our students will be able to attend as many of these types of experiences as possible. So, for example, a student coming every Wednesday is probably not the best plan, because if they came on Wednesdays, they might miss the cardiology clinic one week or the farm clinic another week. So we hope they get a variety of experiences. We also hope it's possible that students are able to work with behavioral health therapists, individuals in WIC, nutritionists, and so some of them might only be there on certain days. So we hope that sort of a schedule can be set up as early as possible to facilitate as many experiences for our students as possible. During the day, you obviously will want to guide your student during clinical practice and supervise their assessment and verification during the experience. So it's a good idea to ask your student to produce the syllabus for the course that they're taking associated with this experience, which is Nursing 487. And they will be able to show you the syllabus and what the goals are and the objectives for the course. Certainly, teaching new skills and reinforcing learning is important. Our students should have most of the skills needed, should have had exposure to most of the skills needed in the clinic by the time they're there. So they will have been checked off on medication administration at that point, as well as nursing assistant skills, such as taking vital signs and that sort of thing. What they might need help with are more specialized skills to a primary care center. So eye testing and ear hearing might be done differently in your community health center than they were taught in their health assessment class. So although they have had some exposure to some of those testing type environments, it might look different to them. So they would need a refresher course. Okay, so now we've talked about the first day being more of an observation day, an orientation day. We would expect the first day and the last day to look very different. Our hope is that with each week, the students are progressing in their confidence levels, in their skills, and in an understanding of the way a community health center works. So each week, they should be given more responsibility whenever possible. This might make you ask the question, what exactly can a student do and what can't they do? So technically, according to the Board of Nursing, a nursing student can do anything that a registered nurse can do, assuming the registered nurse is present and observing, except for hang blood products. However, most agencies also have additional stipulations. So for example, nurses need an additional checkoff to hang chemotherapy. Just because I'm a registered nurse doesn't mean I can go on to an oncology unit and hang chemotherapy. I have to have a certain class that I have to take and pass a certain test and be certified to do that. Anything that requires additional checkoff, a student can never do. Our students, by the time they enter your agency, can function as a nursing assistant and have been checked off and done those skills. Those would include checking blood sugars, vital signs, teaching, lifestyle change education, that sort of thing. Students can also dispense medication, give vaccines, draw blood, but only in the presence of a registered nurse. So skills such as that can be done. And in a community health center, it might be the medical assistant that typically draws blood. Unfortunately, our students can only work under a registered nurse. So if our students are going to be drawing blood, they'll have to be a registered nurse present while the student is doing it. That could become problematic because registered nurses are not always with the patients. They might be doing other roles within the community health center. So our suggestion on how to approach that would be to maybe have certain times of the day where a student's going to give a vaccine or a student's going to draw lab work when the registered nurse is available and present and can assist. We've already addressed how you will be serving as a role model. We also want you to know that if you are starting to identify gaps in knowledge that you think the student should be able to be making at a certain point in the summer, and they're not, please let Megan and myself know so we can start working with the student outside of the community health center to increase their knowledge. We want students to have as many opportunities to learn as possible. So it's our hope that they are able to see multiple areas within the clinic. Planning specific learning experiences when possible is ideal. So as I've talked about, we know that some of the community health centers are open at certain times for certain specialty clinics or stay late for certain specialty clinics. We hope our students are able to have that kind of exposure. There might be some minimal paperwork associated with taking this course. The students are absolutely able to provide you with all the paperwork you would need to sign. It's not very much. I think there's one document, and they'll be able to provide that for you, and that will be listed in the syllabus that you will have seen when you asked your student for the syllabus. So everyone learns differently. Here are 4 common learning styles: visual, auditory, kinesthetic, and intellectual. With a visual learning style, students learn best when they can see the example, diagram, idea map, picture, and images of all kinds while they're learning. An example of a visual learning style is if you're talking about a rash that you saw a patient have yesterday. You can try to describe it as small, raised red areas with a few white pustules in the center, but a visual learner would prefer to see a picture of that rash, whether that be on the internet or in a textbook or whatever. So that's an example of a visual learner. An auditory learner prefers to learn by talking, hearing, and reading, especially out loud. So these students like to read out loud one paragraph at a time and paraphrase it. They like to hear stories with information in it, such as case studies. They like to be able to describe what they learned and how they might apply it. So that is a great time for a student when we're going to talk about daily feedback. An auditory learner would love to be able to recap the day to you. A kinesthetic learning style is a student that wants to do it. They want to touch it. They want to be actively involved in moving and doing in some way. These students are the type that want to practice techniques and perform procedures, do active learning exercises, or complete a project that requires a physical activity. So this is a student that maybe is going to have to take a temperature in the ear and has never done it before. So you could talk them through it. That would be auditory. You can show them a picture of it being done. That would be visual. But this student really needs to work on touching the thermometer and placing it in the ear correctly. So maybe they practice on themselves or they practice on you a few times before they actually do it with a patient for the first time. And finally, the intellectual learning style learns by critical thinking, problem solving, and reflection. The students need to receive the information and have some time to reflect on it, to pull it apart and restructure. You will see these students progressively through the day do better and better. They just need time to process what they're seeing a little bit more. These students like to generate creative ideas and do strategic planning. They like to plan out their day. So maybe when you're doing feedback at the end of the day, you might start planning for the next time you're going to be together and what some goals are for that next time. They also like to analyze their experiences. That can also be considered like they need a debrief. So maybe during their feedback time towards the end of the day, they need to talk out loud usually and make the connections of the critical thinking. So that's the student that might like the question of, so Mr. Smith came in with a really bad cough. And what diagnostic test do you think might be ordered if that cough doesn't get better? And they need a moment to think that through, and they'll process, maybe the concern is the cough is related to pneumonia. And even though their lungs didn't sound too bad, it might be helpful to get a visual image of the actual lung. And that processing time is really important for them. That is an intellectual learning style. There are 3 learning domains. And every time you begin a teaching session, you need to consider the domain or the combination of domains that you are teaching. So the cognitive domain focuses on the student's knowledge and intellectual skills. Students, when operating in the cognitive domain, are thinking about lectures, presentations, tests, written materials. You ask the student to recall information. You ask the student to show an understanding by joining 2 or more concepts. And then you merge those concepts and apply this knowledge to a new situation. So maybe you have a student that's come in this week, a patient that's come in this week that has a high fever. And last week, a patient that same age, same complaint, also had a fever. The student then needs to think through, okay, well, I'm going to apply the knowledge I learned, which was came in with a high fever, similar age, similar presentation, and I know last week we tested the patient for the flu. I bet this week we're going to go ahead and test the patient for the flu too. The psychomotor domain, on the other hand, involves touching, and those are really more of our skill sets that we think about. We think about skills such as Foley insertion, which you probably will not be doing in a primary care clinic, but Foley insertion, blood sugars, maybe obtaining a urine specimen and doing a dipstick, those sort of things. So they focus on the skills and physical abilities. There are 3 ways to kind of evaluate within the psychomotor domain. One is imitation, so you ask the student to complete a return demonstration of a skill. One is practice, where you let the student all day take all of the blood sugars. And by the end of the day, they feel super confident on taking those blood sugars. And then certainly habit. The more often that they do it, the more comfortable they become in it. Finally, there's the active domain, and that focuses on the student's emotionally based behaviors. These teaching strategies often include reflective exemplars, self-assessments, discussions, storytelling, and peer reviews. We want our students to be competent in these 3 areas: technical, interpersonal, and critical thinking. Technical competence is the most familiar and objective skill domain. These are checklists. They're measured by direct observation and psychomotor tasks, Some examples would be drawing blood, verifying accuracy of charting, identifying a problematic lab value, starting an IV, those sorts of things. That shows a technical competence. Interpersonal competence refers to the effective use of interpersonal communication when working with patients and their families. We consider this skill just as, and all three of these skills are just as important as each other. So sometimes, because of the level of our students at this point, they can be very, very task-oriented and focused on technical competence. We encourage you all to not allow them to just focus on technical competence, but to see the value of strong interpersonal competence. So how do they greet the staff, the patients, and their families? Do they call the patient by their preferred name? Do they display proper phone etiquette when answering the phone? Can they anticipate patient and family anxiety? When a 5-year-old is getting a vaccination, most 5-year-olds will be uncomfortable. Does the student recognize that and maybe immediately put the child at ease by asking about how kindergarten is going, or focusing on an upcoming break or a TV show that students know 5-year-olds enjoy? Another important part of interpersonal competence is, do they get along with the staff and the other team members? So do they feel part of a team, and are they engaged with the other members that work there? Finally, critical thinking, which is also known as decision making. This addresses the student's ability to practice principles of critical thinking and problem solving. You must be creative in how you measure this. It is not quite as concrete as interpersonal and technical. This is because all students have different abilities and different strengths. But what we want to see our students do is to be able to ask why questions. We want them to ask you why questions, and we want them to be able to answer your questions to them. We want students to be able to look at a certain event and see that it's part of a larger whole. So just because, that is identifying system errors. So if every time a patient comes in, they're waiting 30 minutes, and patients throughout the day are getting increasingly frustrated, does a student start to recognize that? Does a student start to use their own intuition and hunches when problem solving? That will come with experience, and this should improve as the summer goes on. Finally, do they seek advice? We expect them to be able to ask you questions, but once you've answered a question once, if they continue to repeat the question, that can be problematic and should be addressed. One of the most important roles you will have is in providing feedback. There is both positive feedback and negative feedback, and we encourage you to use only positive feedback. That does not mean that we don't give constructive criticism. So positive feedback affirms or reinforces the preceptee's or student's clinical performance. It allows for feelings of success, it enhances motivation, and it reinforces the desired performance. When you provide feedback, you always want to describe specifically what was observed and give the situation in context. You don't want to generalize or make assumptions. Negative feedback, on the other hand, inhibits or modifies the student's clinical performance. So, for example, saying you did not document that assessment correctly is an example of negative feedback. A better way to say that is using the method of constructive feedback. The way you do that would be to say, I looked at your charting and most of it looked really well, but there were some areas that we need to work on. Let me pull them up and we'll go through the areas that I identified needed improvement. And during this process, please let me know if you have any questions. That would be the good way to give feedback that isn't just positive. We know that repeated negative feedback, again, saying comments like, you did not do that correctly, or you always seem upset, They tend to discourage and demoralize students. They limit and reduce their motivation for learning, and they disengage. We don't want feedback that focuses on what not to do, but rather what they're doing well and what could be improved upon. One effective way to give feedback is using the BEER method: behavior, effect, expectation, and result. Behavior is identifying what the student is doing or not doing that's not acceptable. Effect is explaining why the behavior is unacceptable, how it hurts productivity or performance. Expectation is what you expect the student to do or not to do to change. And then result is what will happen if the employee changes, which is positive, or what will the consequences be if the behavior continues, which has a negative tone to it. The more you give feedback about uncomfortable issues, the less uncomfortable these feedback sessions become. Challenging issues don't have to mean giving mean or negative feedback. Take a proactive, not a reactive approach, and that will strengthen your relationship with the student and head off those really nervous discussions that can happen when you're trying to give feedback. Here is a case study using the BEER feedback method. Your student, Sarah Beth, has come in between 5 and 10 minutes late the last 3 shifts. She always has an explanation. Once she missed the bus, another time there was a flat tire on her boyfriend's car, and the third time she could not find her apartment keys to lock the apartment on her way out. How and when do you approach her with feedback using the BEER approach? So first I want to talk about when to give feedback. So the best time to give feedback is a set time of the day every time you work with the student. And you know your community health centers far better than I do as to what is the best time where things maybe are a little slower and you can spare a 10 or 15-minute feedback session. It could be after it closes and as you walk to the car. It could be over lunch. It really shouldn't be before lunch because you haven't had enough time to see how the student is doing that day. It should be in the last, hopefully, the last third of the day that you spend with your student. The only exception to this is if a student is, which shouldn't happen, but if a student is about to do something that is unsafe, that involves a patient or their family. If the student is going to do venipuncture and you can see that they're heading for a vein that is not going to be easy to get, and you see another huge vein that would be a much better choice, I would provide that feedback in that moment to prevent a patient from potentially being stuck twice. But for the most part, the time to give feedback is a set time every day. So how would we communicate with Sarah Beth using the BEER method? Well, if you recall back to the BEER method, the B stands for behavior. So I would say, Sarah, the fact that you've been late for 3 times is really not acceptable. When you're late like that, it actually can slow our entire day because I try to hold off in calling the first patient back until you arrive. And being 5 or 10 minutes late can actually change the schedule for an entire day for a particular provider. I really need you to try to get here 10 minutes early every time, just so I'm sure you're ready to begin the day. If you can do that, that would be wonderful. And I think that would really help with how I evaluate you on professionalism. If you're not able to do that, I'm probably going to have to talk to one of the clinical faculty in the School of Nursing. Do you have any questions? When you're providing feedback, you always want to use descriptive rather than evaluative terms. You always want to be specific. Here's an example. To say to a student, I just don't think you're making the necessary connections, sounds very different than, I've noticed that for the last 2 patients that we had to get a CBC on, you didn't seem to understand why. Remember, both of these patients came in with a nagging cough and a fever. And so I believe that the reason we're getting a CBC is to check that white count. As you know, an elevated white count is indicative of an infection. Let's try to keep that in mind as we move forward. And if you have any questions about that, let me know. We always want to focus on their behavior rather than their personality. So for example, let's say you're working in a particularly small community health center. And a student, when they're calling the patient back, is talking really loud, and everyone stops and turns around and hears the patient's name being called, and everyone looks up, and you actually have seen a few people startle because it's a small place and the noise is loud. Instead of saying to the student, you're really a loudmouth, keep it down. Even if you're joking, the better approach would be to say, we always have to use such a quiet voice when we call people back because it can be so disruptive in such a small work environment. Focus on sharing information and not giving advice. Keep the feedback well-timed. Again, the preferred time to give feedback is in that final third time period of the day at a set time every day. Always give your student time to accept and reflect on feedback. My experience with students is that it is human nature when somebody is giving a student constructive criticism or constructive feedback for the student to immediately try to defend themselves. It just comes out. Sometimes we all do that. We just can't help it. So a really good way to head that off is say, I don't need you to say anything right now, but I've noticed X, Y, and Z. Let's talk about that the next time we work. Or let's talk about that as we walk to our cars later on today. So the student has some time to sort of marinate and process what you're telling them. And you've given the student permission to not respond immediately, but to have an opportunity to respond at a later time. Avoid getting the impression that you and your staff are ganging up on the student. One thing that I would say is really helpful is when you notice a behavior that's concerning to you, just make it about you. I've noticed that you do X, Y, and Z. When you do that, I'm concerned that A, B, and C is going to happen. That sounds a lot better and is much easier for a student to process than all of us have noticed that blah, blah, blah. Because that makes a student feel like a failure and that people have been talking about them. And that's always a disconcerting feeling for anyone. Now we're going to talk about another method of feedback, and that is using your cuss words. Cuss words are used to clearly communicate a rising level of concern for any issue. When you say the phrase, I'm concerned about, the word concerned is being used to get your students' attention and to ensure that they are actively listening to the concern. If you tell the student, I'm uncomfortable because it conveys the message that you believe the student may have missed the expression of concern, which is now elevated and at risk of turning into an error or a dangerous situation. Finally, when you say, this is a safety issue, the action must stop and be evaluated before continuing. This common framework of 3 simple words provides all team members an attention-grabbing communication tool, as well as a clear idea of the level of importance associated with the information. But just like any feedback method, these terms should only be used when warranted if they're going to become a part of a useful, if they're to become a part of your safety culture. One thing I will caution you about with safety is that our students associate unsafe practice and failing a class. So we reserve your behavior as unsafe for very serious situations. Unfortunately, some situations do warrant that, but our hope would be that once you express the concern, that behavior would cease from the student. So these are 3 useful terms: concerned, uncomfortable, and safety, each one elevating the issue a little bit deeper. I think this is a very realistic scenario that you might encounter with a student. Your student, Mark, has consistently been professional, had a strong work ethic, and shows a great deal of kindness and compassion to the staff and patients and families in your clinic or community health center. However, there's some critical thinking connections your concern Mark is not making. Some examples include being not prepared to do patient education on Lovenox injections that are going to be given at home, and that medication is new to the patient. Another example is that Mark was not able to answer why reviewing diet and nutrition was so important for a patient who started taking Coumadin last month. Finally, Mark could not explain why a chest x-ray and CBC was part of follow-up care for an elderly patient with a persistent cough. How and when do you approach him with your feedback using cuss words? So one thing you have to be diligent about is in evaluating, is this going to be your first time giving Mark this type of feedback? I'm going to assume that it is. And where you are is that you've noticed these 3 troubling scenarios that lead you to believe that certain connections and just a level of preparedness is not where you think it is. So on the 3rd day, so let's say that's the day with the chest x-ray and the CBC, about an hour before you all are going to leave, you have an opportunity to talk to Mark about feedback. And how do you approach this with Mark, who you really like, right? He's a nice guy. He's been coming to work on time. He's professional. The patients and their families love him. He works really hard, does every task you ask him to do efficiently. But there's just those critical thinking connections that he's not making. How do you convey that in a way that you feel is appropriate? So it's 5 o'clock, it's towards the end of my day, it's our daily feedback time, and I'm going to do it. How am I going to approach this? So I think the best way to approach it using the cuss words is to start with the concerned. So I'm not going to go down to the uncomfortable and the safety at this point. This is the first time that I've talked to Mark about that. And I'm going to assume that maybe 1 or 2 of these instances happened in the same day, because we wouldn't want this pattern to evolve over 5 weeks. We'd like to sort of nip it in the bud, especially if we're looking at it as a concern. We want to nip it in the bud pretty early. So the way I would approach Mark during my feedback time, because he knows he's going to get feedback right now, so this should not be a surprise to him, is to say, Mark, I really enjoy working with you in the clinic. I think you're doing really well. You're super professional. I love your work ethic. I know you're working really hard. The patients and the families love you. The level of compassion that you show is phenomenal. I'm really pleased. There are some things that are starting to concern me, though. What's concerning me is I'm seeing a pattern of critical thinking that is not as deep as I would think it should be at this time. So let me give you some examples. And then I would go into the Lovenox example first. And I would say, you knew the patient was going to be started on Lovenox, and there was no preparedness on your end to try to do patient education, even though I know you've seen a couple other patients be started on new medications. So it would make sense that you would be aware that patient education is going to be needed. Another time was when you couldn't answer why the diet and the nutrition was so important for a patient who started taking Coumadin. Now, I know you've had pharmacology in the past, and we had ample time during the day to do a simple Google search or use a different type of um, pharmacology software to look up that medication. And one of the big aspects of patient teaching is the amount of consumption of your leafy green vegetables and how that can alter their INR, which is the lab test that monitors the level, the dose of warfarin. So the fact that you didn't do that sort of concerned me. And then today, with the patient with that came in with a persistent cough, who was older, you know, I think it was clear that there was a concern he had pneumonia based on his symptoms. And I know you heard us talking about the possibility of pneumonia when we left the room. So I sort of would have thought you would have connected the diagnostic tests and labs of a chest x-ray and a CBC to pneumonia. I'm wondering if maybe we need to review some of the medications with your nursing faculty, because all of these examples really had to do with medications, and maybe that's not your strong point. So what we could do is I could introduce you to this pharmacology software that we have here in the community health center for you to look up. And I'll make sure you have time to do that before we go into the patient's room. Or maybe you even have that on your app. And while out of the sight of the patient, you could quickly look it up. It's also probably a good idea that you start writing down the medications that we're dealing with during the day and keeping a running list, because you might see us use these medications over and over again. Do you have any suggestions on how you can improve with the medications? Because a big part of working in a community health center is being able to do patient education on new medications. And so it concerns me a little that you've missed these 3 medications. Let's see if we can improve on this moving forward. Does that sound like a good plan, or do you have any further suggestions? Evaluation is often confused with feedback, but it's actually different. So evaluation is often more formal and it's written. It comes up with a future-oriented spin on it. So you're collaborating a plan moving forward. It addresses both positives and negatives. And because this is a relatively short time you'll have with our students, the big expectation for evaluation is this end of experience evaluation. So feedback is something that we want to occur every time you work with the student. An evaluation should never be a surprise because you've expressed your feedback every week with the student. When you give this when you give this end of experience evaluation, you want to make sure you're in a quiet, uninterrupted environment. So the evaluation piece really should be done at a time where you're not both working. So that might just mean right after your last shift together, you, I don't know, when the clinic is closed, maybe you take 10 or 15, 20 minutes to go over this evaluation. It should be relaxed and professional, and the student should definitely be put at ease. If there have been some significant issues along the way, the clinical faculty, including Megan, Dr. Williams, and myself, will be involved. You always want to give specific examples of both positive and negative behavior. And you address the student's future needs and goals. So even though your time with the student is complete, the students will go on to work with other preceptors in different varying settings. And so some of the awesome aspects that you've identified the students have done, like their relationships with the patients, their cheery attitude, their strong work ethic, you would want to encourage them to continue to develop those attributes and bring those into wherever they are next. And some of the areas that you have identified that need additional work, maybe that is increasing their knowledge base on medications and some of the side effects and concerns and nursing implications associated with medications, then you say that. I think you've been wonderful with A, B, and C, but I do think what you need to work on moving forward, wherever you may be, has to do with your knowledge base surrounding medications. Again, highlight what is the difference between feedback and evaluation. Feedback is daily. You're going to set a specific time every shift to do this, and you're going to be really specific with examples coming from that day, and if needed, you'll show a pattern. You'll take a beer approach, and remember what beer stands for: the behavior, the effect the behavior is having, the expectation of changing the behavior, and then what will happen, the results. Or you can take more of a CUS approach with this concerned, uncomfortable, safety, with each level rising to more of an urgent situation. With evaluation, you want it to be affirming, it's more future-oriented, and it's very reflective because you're reflecting back on all the experiences you've had with the student, and you're also reflecting back on all the feedback that you've given the student. And the student should be doing that too. So hopefully they will see that they have progressed over their time with you. And some of maybe the feedback that you gave them that was constructive evaluation at the beginning was successfully overcome and improved over time. And that was not something that they heard, towards the end of their experience with you. We want to thank you again so much for working with our students. This is such a unique experience for them. We're absolutely thrilled they get to work in these wonderful community health centers. We know you're all doing wonderful things for the patients and families in our community. We sincerely appreciate that, and the students are thrilled to be a small part of it. Again, if at any time you have concerns, Dr. Megan Williams and I'm Dr. Louise Fleming, please contact us. You have our contact information through the nurse managers. We are happy to help in any way.